Hi, my name is Kate Harris. I'm a consultant to the Bill and Melinda Gates Foundation, and I'm a member of the Activity-Based Costing for Management's Technical Working Group. The purpose of this presentation is to walk you through ABCM's methods so you can better understand how this data comes together and compare this approach with others. First, some acknowledgements. Thank you very much to all the different people who have contributed and reviewed this methods comparison effort. This presentation will walk you through the ABCM's purpose, its key outputs, the methods, including as they relate to the quantification and allocation of human resources, indirect costs, equipment, and the commodities, as well as the cost and complexity of implementing this method. We'll talk mainly about activity-based costing, but we'll also make note of how this may differ from other costing studies. In summary, three key messages. One, activity-based costing for management is more similar than it is different from most traditional costing studies. There are some differences in study design and methods, but it's largely more similar than it is different. On the second point is that there are some differences, and noting that ABCM is unique from most costing studies in that it includes community level and above site costing, which most costing studies do not. It includes data ecosystem mapping and assessment, and it has the intention to be institutionalized and routinized. Last, ABCM's methods continue to evolve to improve its outputs and study efficiency. Starting with study purpose. The main purpose of activity-based costing is to identify areas to improve efficiency and inform effective resource allocation for both HIV and primary healthcare programs. So for example, this data can be used to optimize program configuration and resource allocation decisions. It can also be used to optimize patient experience and care at the point of service. This overall study purpose is very similar to other traditional costing methods. There may be more detail in some areas and others that lends to have more detailed policy implications in those areas, but it's largely the same. For example, ABCM data has been intended to be used in Tanzania, for example, to inform its national strategic plan and to better understand the costs of the UHC benefits package. PEPFAR intends to use the activity-based costing to inform its resource allocation and spending decisions, but notably, it won't be using the unit cost that activity-based costing will come out with for its target-based budgeting process. That's not the purpose. It's more to understand overall efficiency and program design and optimization. In terms of key outputs, so activity-based costing comes out with average unit costs, things like cost per person on treatment, and the other outputs also include these three things. One, a detailed patient flow analysis. So what activity-based costing does is first walk through the system of what a patient should experience when they need a particular service. So what are the steps that they should follow at a clinic or health facility? How much time should they spend with different staff members, for example? And then they do another patient flow analysis of what they actually observe. Where did they see patients? How much time did they spend at different steps? Were there steps that were missed? Were there steps that were added, perhaps? What medication did they receive? That's what we mean by detailed patient flow analysis. And then you compare what steps they should do and the time they should spend with what they actually do to get a sense of things that might need to be optimized or process efficiency. Second, the ABCM comes up with capacity cost rates to measure the cost per minute of use of somebody's time, personnel, or equipment or facility resources. So when you get this cost per minute to use that resource, combined with the process times from the detailed process patient flow analysis, that gives you information that you know on the amount of money that it costs to go through the different steps. And finally, activity-based costing also does patient exit interviews, which offers insight on the patient experience from that service, as well as ask about how much it costs the patient, for example, on transport to get there, their out-of-pocket spending, as well as the opportunity cost of seeking care. These types of outputs are quite similar to other costing approaches. They might have different names, they might have different levels of detail, but those outputs to understand the patients moving through the system, these unit costs, the costs of equipment and commodities are largely the same overall. Also on scope, got to get into actual and normative costs. Activity-based costing use actual costs, meaning it estimates and it calculates based on the observed costs that are actually used, not on normative costs or the costs that we should be incurring. So it's an observed study, which is usually what other costing approaches are too. If needed, activity-based costing could be expanded to use prospective changes of what it might cost if we changed this care process or this location. But currently, it is about observed costs, actual costs. In terms of the scope to include community-level costs, activity-based costing does include this, but with two caveats. Community-level costs, for example, things that are activities that occur above a facility but below the national level, are community-level costs, and those are included, but they're only included for PEPFAR paid for ones. We don't have the data, including in this study right now, for Global Fund or government or other funding costs. So they're included, but just for PEPFAR. And the other thing to note about these community-level costs are they sourced from a top-down approach, not bottom-up. So we haven't calculated these at the community level and added them and done time-driven activity-based costing to understand how much those are, but rather got broader numbers from a headquarter level and cascaded them down. This is one of the areas where the method is evolving with the intention to also collect community level costs with this activity-based costing bottom-up approach. The same is true on above service delivery. These are currently included in activity-based costing, but with the caveat that these are also sourced from a top-down, not bottom-up approach right now. And that is that it leverages the Global Fund PEPFAR resource alignment effort, which includes some secondary country data in that resource alignment. And that country data is the data that is submitted to the Global Fund through the funding request process. So with that data on the costs of above service delivery, whether that's program management or these other broader system level costs, and then they're allocated down in a top-down approach. These two areas are quite different than other costing methods. Most costing studies, it's something to ask about if they are included. Most don't include the community level or the above site, but rather they focus on the facility level. So it's something to ask about. Above activity-based costing includes all funding sources, meaning all costs are included no matter who is funding that at the community level, which is the same for other costing methods. You could think of activity-based costing in types of modules or things to ask as you're looking at another costing studies of what's their scope. So activity-based costing scope or modules includes this facility level costing, this bottom-up, these actual costs, which often other costing studies do, on the process map for detailed patient flow analysis and knowing how a patient moves through the system, what are the steps they go through, often included in other costing studies. It also includes asking about out-of-pocket spending, transport costs, for example. That's also often included in other costing studies. The modules that are included in ABCM that are often not something to ask about in other approaches are things like patient satisfaction assessment, community level costing, above site costing, and data system landscape assessment. So that's kind of an overall on the scope of activity-based costing and questions you might want to ask about other costing studies if they are included, so you know what the data is that you're working with. In terms of frequency of the effort, the intention here is for activity-based costing to be done in a routinized, institutionalized fashion. The intention is that those process maps following the patient and how they move through a healthcare facility would be to be done every 2 or 3 years, or whenever there's major changes to a care process or staffing assignments, for example, that would change that patient flow analysis significantly. The intention is for the costing elements of that to be done routinely or annually to understand where the money went and how much it cost. This intention is quite different from most traditional costing methods, which are usually either a one-off study or perhaps every 3 to 5 years. There's of course exceptions, so it's good to ask of is an approach meant to be a one-off or not? But the idea is that activity-based costing is that part of the reason that it is meant to be routine is that M at the end, activity-based costing for management. If we can get data more routinely and annually, it's it's more easier, more accessible to use this for a management approach if you can get data more quickly and react to it more readily. And the other point is data access. The intention of activity-based costing is for countries to have full data access so they can use it to inform their country-owned management of their health system. That's the intention. Sampling method. So how is it that within a costing study, you don't cost every health facility in each country? You have to pick which ones are going to be included in the study. And this is done in the same ways as most costing studies, in that there's a combination of purposeful and random sampling methods used. So far, we have data in ABCM from Tanzania, Uganda, and Kenya. And notably, the Tanzania and Uganda sites were included for HIV, whereas Kenya was both HIV and primary healthcare. In Tanzania, there's 22 facilities. And in order to select those, there were 6 regions that were selected randomly from 4 national geographic zones with the highest HIV prevalence. Then 5 facilities and the different councils were from each of the sampled regions were randomly selected. And then facilities had to be, the criteria was they needed to be operational for at least 2 years or more. And then there were some facility characteristics that were overrepresented, needed to be replaced to get to the targeted distribution criteria. And that was very similar to how Uganda and Kenya was done, and that's a pretty standard approach. In terms of the method on whether something is top-down or bottom-up, for activity-based costing, it's a combination of both. But generally at the facility level, it was mostly bottom-up costing, meaning it's mostly an ingredients-based approach where you're understanding how much equipment, et cetera, is used, and you count them all together to get to your unit costs, and up you go from there. There's one caveat here, and that not all facility level costs were included in the bottom-up methods. For example, some non-service delivery costs like cleaning costs were included in a top-down method, whereas in other costing studies, they include those in their bottoms up as well. But for the most part, facility levels are bottom-up ingredients-based costing, which is similarly done at the facility level. Notably, some studies also do top-down at the facility level. So in addition to saying, okay, here's my ingredients for all of these things, and they add up to this, some studies then take the total amount. So let's say you have the total costs of wages in that clinic and then cascade them through to different services. And when you compare that top-down allocation versus the bottom-up, you can find some efficiency insights by comparing those 2 data. So for example, that was done in a value TB study, that top-down versus bottom-up, whereas ABCM doesn't do the top-down and bottom-up at the facility level. Rather, they just focus on bottom-up activity-based costing at that level. At the community and above site levels for activity-based costing, this is when it's done top-down. So we get the data from a central repository and then cascade it down to get to allocate it to different services. And this is different for other costing studies, as we noted that often that community and above site level costs aren't included. But if you're looking at a study where they are included, it's good to ask of how they have been calculated. Now to talk about human resources, this is often one of the biggest cost drivers in unit cost, so it's important to understand how it is quantified and how it is allocated. For activity-based costing, this is the time-driven activity intervention-based that follows the patient, not the staff member, in order to quantify how much time is spent with them. They also include in this estimate non-patient facing staff time, such as medical records documentation, scheduling, prescriptions. And how they do this is that when they're doing those observed site visits, they're following the patient and tracking when a patient goes inside a clinic room and comes back out, and noting how many minutes these things have taken. There comes a question about idle time. How do you include the cost of time where a health worker is not seeing any patients? Maybe there's not enough patients to see. For example, activity-based costing includes these as available clinic minutes. So any available clinic minutes are included in their capacity cost rate, which we'll come to, net of breaks or time off or non-clinical data reporting or training or conferences and the like. But you are available even if there's no patients to see. And so then they can get another data point on available minutes versus minutes used. And the difference is your idle time. You're not seeing anybody. That's included in some way, but it's quite different than how it's included in others. It's a good thing to ask in other costing studies of how it's done and how that idle time is looked at. Most costing studies use a bottom-up approach, which doesn't usually include the idle time. It's number of minutes that a healthcare worker might see a patient times their wage, et cetera, and as you go. Some studies, for example, Value TB, when they do their top-down allocation, that can give you a sense of how much time wasn't used, whether that was idle or whether that was for training or data collection or something else other than patient-facing time. And so you can get that estimate. So it's an important note to look at how that idle time or how non-clinic facing time is used. Capacity cost rate is an important dimension of activity-based costing, so we just wanted to spend a minute to explain what it is and how it is calculated. It is a cost per unit of time of each type of personnel, furniture, equipment, facility space used during the care visit. And then it is multiplied by the time for each of the step at the individual level. It's important to note that this capacity cost rate doesn't tell you about efficiency. It just tells you how expensive something is. So it has a numerator, which is the cost, and a denominator, which is the time used. So the numerator is the cost of the resource for an interval of time, and noting that this is the full salary. So let's say the full salary, benefits, everything it costs for that person is $10,000 US a year. And the denominator is the number of minutes of practical capacity over an interval of time. So the number of minutes available for work that is net, taking off of breaks, time off, non-clinical time, data reporting, training, conferences, all that kind of thing. So those are the minutes available. So let's say that nurse, it costs $10,000 US a year. He or she has 100,000 minutes available for clinical care to see patients. So when you take that 10,000 divided by 100,000 minutes, you get to 10 cents a minute. So if that nurse contributes 5 minutes per visit, that costs 50 cents per a 5-minute visit. Now this cost is the same whether or not the nurse sees one patient a day or 100. So that idle time doesn't change anything. That's how much time it costs she or he is available to see patients. So you can, as we talked about, note the difference of minutes supplied or minutes used as unused minutes, but it doesn't change this capacity cost rate. And it's this capacity cost rate, so this 10 cents a minute, that is then times by the clinic time that is used to understand the unit cost through the activity-based costing method. The same, this is an example on HR, but you could do the same on equipment. What's the amount of time I have to use this equipment? How much does it cost to run and maintain that equipment and get the same CCR? On indirect costs and above service delivery, the scope of the indirect costs includes, in activity-based costing, includes things like salaries of administrators, cleaners, security personnel, utilities, anything that is required to keep the facility going. And that's the same in other costing approaches. And how these are quantified and allocated is by these capacity cost rates that we were just speaking about. And so the cost for each of those indirect and how much is used is then applied to that service. On non-service deliveries, these are the top-down methods. So some of these indirect costs, like cleaning, is not collected at the facility level. Some of those things you have to go to the district level to collect. So those are top-down allocation. But for most of them, it's used bottom-up, using this capacity cost rate for that particular thing. It's something to ask about on other costing methods, how they quantify and allocate those indirect costs. Some of the quantification can be different. They can quantify the total costs of anything in the facility from a bottom-up approach, as opposed to using this capacity cost rate. And allocation is often similar by some notion of time spent or square meters of how much you're going to use that indirect cost towards that service. Commodity cost is an important one because that, like HR, it's another big cost driver, so important to understand where the data is coming. In activity-based costing, on the quantities of the commodities used, it is assumed that the clients receive the right regimen. So, for example, first-line drug or second-line drug, or how many drugs, and that they take the correct number of pills or other commodity. There is questions in the client exit interview to ask about commodities used, dispensed, did they receive the right ones? But the assumption and default is that they received the ones, the right regimen per the policy of that country. On wastage and stockouts, so wastage is not specifically captured in activity-based costing, and that can be quite significant to know about. Stockouts are somewhat monitored, and asking clients during exit interviews if they've received their medicine, and if they didn't receive their medicine, it might be a sign of a stockout. But it's not more systematically collected in activity-based costing that way. In other costing studies, something to ask about how they do calculate these commodity costs. So sometimes it's observed, sometimes it's about stocks allocated, sometimes you might get a lump sum estimate that cascades down, and so then that would include stockouts. So given the importance of this cost driver, it's something to ask about of how commodity costs are quantified and allocated in the study. On price data, there's also some differences here. First, on activity-based costing, I'm talking about how we then price the commodity. So we assume that the patients are receiving their correct commodities in terms of quantity and type, but how do we get the prices? Prices here are the average costs of the commodity used that is observed. This can be different, something to ask about in other studies. Maybe they're from national commodity price lists or other price lists out there instead of observed costs currently, and that can have some fluctuation. So something to ask about given the significance of this cost category. On price input data on staff, again, another big cost driver. In activity-based costing, this comes from facility records and some government treasury rates, whereas in a lot of other costing studies, sometimes it is government treasury wage rates that are used and not specific observation, sometimes depending on data access issues. So something to ask about. On equipment, this is used with capacity cost rates of replacing the item, and on space, its cost of construction, useful life of a space. So somewhat similar, and these aren't the biggest cost categories, so it's not as much to worry about. In terms of what it takes to actually conduct an activity-based costing for management study, so in terms of time, different components of how it takes about 3 to 6 months to design the study and the tool. And this range can get caught up in ethics approval or identifying partners. So there's quite a range. On data collection, and granted this occurred during COVID, so there was some pauses, that can take about 2 to 4 months. And data analysis, data cleaning, that could take another 2 to 4 months. And then another 2 months after that to contextualize and vet the findings, results with different teams and stakeholders can take that time. This can be quite similar to other costing methods, but you could ask about the timing for those. It can be faster if there's local hiring or differences in ethics approval process, or if you have already partners identified, but that's how long it took for some of the activity-based costing approaches. On the costs, it can cost about $350,000 to $400,000 per country on 20 to 30 facilities. And this is ballpark range of other costing studies with these similar approaches. And it can be much more efficient if local partners are used, can take the cost down substantially. So in summary, activity-based costing is more similar than it is different from most traditional costing studies, with the nuances and the differences that we've discussed today. Some of those differences is that ABCM is unique from most costing studies in that it includes community level and above site costing scope. It includes data ecosystem mapping and assessment, and it has the intention to be institutionalized and routinized. So hopefully in learning about this gives you an idea of things you could ask about on how to interpret the data. And finally, activity-based costing methods will continue to evolve to improve the output and study efficiency, including in the community level and above site costing component, as we've discussed. And that's it. Thanks so much for listening.